Jim, to begin with you, if our audience aren't familiar, because we want to be really inclusive and bring everybody in, give us an insight into terms of your relationship with M42 and a quick insight in terms of the Longevity Forum.
Thank you very much, Amandeep. Well, our relation with M42 is becoming stronger and was evidenced in November of this last year. His Excellency Hassan Al-Nawais came and spoke very effectively at the conference that we put on every year. It's a not-for-profit in London that seeks to explain the science of longevity as well as the effects of the science of longevity in social terms. This year we're doing it again, and we're going to talk about the corrosive effect of loneliness in old age, which is one of the principal causes of early mortality in older people. And the other Jim and I were talking about that earlier on. It's a very, very major theme that I think will become more apparent as time goes on. But generally speaking, we have a science day at Oxford University, and we have a day in London when we talk about social sciences. And it was co-founded by myself, Dafina Grabci, and by Professor Andrew Scott, who wrote The 100-Year Life. So it has a good coverage, and it's now in its 8th year. And we're very grateful to M42 and in particular His Excellency for supporting us.
Fantastic, and it's great to hear about the leadership visiting London, my native city, and having that collaboration. Jim, we're going to come back to that because the Longevity Forum really speaks to the title of this session, Making Prevention Happen. To bring in Dr. James Mault, again, please give our audience an insight in terms of your relationship. You are a key member of the advisory board for M42.
Well, thank you. And really, when we started this journey, it was all about trying to find ways of collecting and capturing more rich data from the human body and making that available in ways in the past we never had to be able to take better care of patients. And with Hassan's leadership over the past 3 years, it's really been a remarkable opportunity to collaborate. And it's truly a collaboration of building these capabilities, because it's really moving into a new era of how we take care of patients. And when we talk prevention, to proactively identify problems both in the hospital and at home, and not just acute disease, chronic disease, but also preventing disease. And the way we do that is by having these data sets and what we call signal, like never before. And really that spirit of innovation, especially with what M42 has assembled with genomics and proteomics and Malafi as it relates to the electronic records.
Well, we're going to get into more of those details with you, Dr. James, and we have a special session with you later as well.
Great.
On BioIntellisense. So I'm going to come back to you, but to bring in Dr. David Rhew, Healthcare, Microsoft, big headlines about the Microsoft and UAE collaboration across many different sectors. It's wonderful to have you here with us, Dr. David. Since the Global Healthcare Week in Abu Dhabi, bring us up to speed about that relationship here with the UAE and with M42.
Yeah, so one of the things that Microsoft has committed to doing is to work with organizations across the globe to identify ways that the technology, and specifically cloud and AI, can help advance the cause and do things that are previously very difficult, if not impossible. And as we think about prevention, it will require massive amounts of data for us to be able to understand what's going on, an ability for us to be able to leverage the latest AI technologies to be able to identify individuals and then hopefully bring these individuals to care. So that will lead to more proactive care, lower cost, and better health outcomes. And that's what we're committed to. We're excited to partner with M42 on this journey. And thank you, Hassan, for including us in many of the activities today.
Fantastic. And to maybe remain with you, Dr. David, let's shake up the order slightly. When we speak about making prevention happen, prevention has been touted for a long time in healthcare across the globe. Why are we still at this stage? Why are we still seeing more hurdles than solutions? Why the focus on this right now?
Well, one of the things that I think is important to recognize is that there has to be a business model behind it. And then we have to understand who's paying for it. So if we can align the incentives and the reimbursements to doing the right thing, we have an opportunity to potentially be able to create an environment that supports the prevention and the proactive care. But the second thing that we see is also very much more related to the process. prevention isn't just about education. It's not about a screening program, but it is involving identification of individuals that are at highest risk for complications, bringing them into a system that oftentimes is already very clogged. That means risk stratifying and triaging, and then enabling the individuals on the receiving end to understand what they are being asked to come in for, why it's important, and helping them, whether it's enabling them transportation or making it easier for them to have those appointments. And all three of those things have to be done in a very seamless handoff. And that's one of the things that we can do through the technologies by making the process easier for the consumer, easier for the clinician.
So it's a holistic approach to the whole ecosystem, making it easier for the clinicians as well as the patients, and I guess an education journey. To bring in Dr. James Mault, when it comes to wearables, building on what Dr. David Rhew is saying there, innovation, technology, they're at the forefront of prevention.
Yeah, it really is. I mean, what's clear now is we're in an unaffordable predicament. We can no longer afford to take care of patients in a crisis management approach. And so we need to be able to move upstream and be able to see things early enough that, you know, prevention is a much lower cost point than treating the end disease. And so to be able to do that, you know, again, Dr. Rhew and I have been collaborating. There are things that we can see even in a routine eye exam, in the retinal scan, that is a foretelling of a very important disease states that we can get in front of and treat at a much earlier time frame. Same thing with wearables. We're now in a position to be able to collect data off of the human body and be able to see how you walk, how you sleep, how your heart's beating, and how you're breathing. And that's allowing AI then to be able to look at these data sets. We now have 2 billion data sets of just continuous longitudinal information across multiple parameters. And that's allowing us to see things that we've never seen before and prevent what we call hospitalization and deterioration. So it really, over the next 5 years, is about to change everything we do in pretty much every facet of healthcare. It's a pretty exciting time, and again, to Hassan's leadership, I think M42 is uniquely in the forefront of being able to capture these new capabilities.
I think that's really exciting. As you say, the next 5 years are going to be revolutionary. And even since we last met on stage at the Abu Dhabi Global Healthcare Week, which was last May, there's so much progress has happened. Dr. James Mault, you make some excellent points there that build on what Dr. David Rhew was saying there. It's the data collection and the processing, which of course is where collaborative efforts with M42 really come into the foreground. Jim Mellon, longevity. In terms of a very trendy and timely theme, when it comes to prevention, of course, it's at the heart of what you and your colleagues are working on.
That's absolutely correct. We already have preventative medicine in action vis-a-vis longevity. So the GLP-1 agonists are a good example of that. They will be a $70 billion market by 2030. And we don't know exactly what they do, but we know that it's generally good. And this is a glimmer of light in terms of expanding human health span. We've already had prevention for a long time in the form of statins, as an example. So even though someone came up to me earlier on today and handed me a pamphlet saying, "Stop heart attacks forever," I don't know why he chose me to hand it to. Heart attacks are generally going down. It used to be absolutely the major cause of death, but 1 or 2% improvement every year due to statins, blood pressure pills, and so forth is the result of technology and prevention. So we have some prevention already. All the stuff that these guys are doing, which is phenomenal, fits into the fact that biological intervention in the processes of aging is becoming possible and will be here in 10 years' time. So as Brian Johnson, who I don't necessarily subscribe to his way of living, but he does say, don't die. Hang around for 10 more years, because there will be therapies that will enable biological intervention into our aging processes that will not just expand health span, that potentially could add to lifespan as well. We do not want to be old in ill health, but we have to be old because there are too few young people in the developed world and far too many old people, and the old people have to be much more productive. Otherwise, we're going to have a societal major crisis. So keep older people healthy for longer is not just a mantra, it's a necessity and imperative.
I mean, that's quite an incentive when Jim Mellon tells us all to stay alive for another at least 10 years. We hope longer, inshallah. So much to unpack there, Jim Mellon. I'm going to come back to you, but just say to the audience, we want to make every session as dynamic and interactive as possible. If you've got a question, please put your hand up. We have got roving mics. We can bring one to you. So I'm going to give you a few seconds to think about that. Jim, you just said there about prevention. Now, with statins, that's still prevention when something's been diagnosed. Ideally, the ideal is that we get in prevention as a cure before people even need statins, right? Like before we need even medical intervention. Is that not the case?
Absolutely. So all sorts of new tests are coming out. One example is liquid biopsies, which look for, shards of tumors floating around the body. I think this is a very exciting new development, and I'm going in for mine quite soon. But the problem, I think one of the big problems is that there is a disconnect between, as you said earlier on, who pays and what the business model is. And I'll give you just one personal example. I'm due to have a DEXA test, if you know what that is. It's a bone density test. Very important for people who are getting older like myself, because frailty is a very major cause of hospitalization, a very major cause of premature death. And the insurance company won't pay for it. It's £2,500, and I pay £15,000 a year to the insurance company. I'm asking, why won't they pay for my DEXA test when it would save them a lot of money in the event that I had a fall because I don't have a DEXA test? This is the sort of disconnect that we have to break, and it's why it's so important that the data sets are being developed by BioIntellisense and Microsoft are vital to the future.
Well, we certainly appreciate you being so candid with us, Jim, and giving us a very clear insight in terms of your own medical, and maybe the insurance company may be watching. To broaden it out for just a moment, to bring in Dr. David Rhew. As Jim said there, it's about the business model. So if we talk about financing, we are, of course, here in the UAE, and the M42 and UAE leadership thinks in a very philanthropic fashion. The models that are developed here, the technology that are developed here, are rolled out elsewhere. Of course, when it comes to making prevention happen, we need to negate inequalities, further inequalities. Can you give us an insight in terms of this?
One of the transformative technologies that I think is going to change the way that we look at how healthcare is delivered is something called agentic AI, which the AI actually does something. And if we can remove the ability for humans to be able to be involved in the data collection and allow the machinery, the technology to do it, we will have made care more efficient. So to Jim's point about using AI on retinal images, if it requires an optometrist or an ophthalmologist or a physician to use a fundoscope and capture it, that's already a limitation. But what we have now are the capabilities where the technology can actually automatically pick up this image just by looking in it. It auto-adjusts. That in itself is an innovation that will allow us to democratize this capability and put this not only in eye care centers, but primary care, malls, kiosks, and that will then give us the chance to not only screen patients, but potentially allow them to be monitored. And the more that we can start thinking about low-cost, non-invasive, highly accessible, easy-to-use solutions, these are the things that will help us, allow us to be able to then think about those new business models where we're no longer requiring on adding more patients to an already busy healthcare system.
So that's a really astute point you make there, Dr. David Rhew. You're talking about scaling up, allowing the financial backing of these technologies to actually be scaled down, therefore. By democratizing, you make it more accessible.
Yeah, so if you were to look at a broader population, about 5% of the individuals within that population will be responsible for about 50% of all the total costs. 20% of those individuals will be responsible for 80% of the total cost. So if your objective is to oversee the total cost of care over an extended time period, you would want to identify who those 5% and the 20% are. The problem is it's a rotating cycle. You never know who is kind of falling into that risk. But if you imagine a scenario where you have data sets for individual that are secured and allow you to be able to then run the AI on them, you can find individuals that may fall into those categories. I call these individuals ticking time bombs because ultimately any moment within the next 6 months to a year, they could have a heart attack, stroke, or something serious, but we won't know until they come into the hospital or clinic. Our goal is find them, bring them in, be aggressive with the treatments, and get them onto the proper health path. And if we can do that, we can have a dramatic impact in total cost.
I think that sounds like a really visionary model to aspire towards. And again, that's where collaborations here with M42, with all of you and in the UAE are so strong. As you can see, we're really open to questions. I'm actually throwing my cards around because we're having such a wonderful time just being organic here. I want to be organic with you all. Who has a burning question? I can continue speaking to my speakers, of course. However, if anybody's got a question, fantastic. May we get 2 mics to our, can I get my technical team? Gentleman here, can we get him a mic? And then Miriam, we're going to get you a mic as well. So please put the mic right up because it's very loud here. So all the way up and introduce yourself.
My name is Abdullah Khoja. I'm a family medicine and preventive medicine population health specialist. So my question here is, you address the secondary prevention and tertiary...
Sorry, mic all the way up.
You address the secondary prevention and tertiary prevention, where I think it's critical and vital to address the primary prevention and health promotion. So what you can bring to the table when it comes to social determinants of health, addressing lifestyle modification, as I believe that there is a huge gap in utilizing the technology and the analytics and AI when it comes to address and empowering our population. It's not about only DEXA scan or statin. Statin and DEXA scan is secondary prevention.
Sure, brilliant, great question.
So I think that there is a huge work that needs to go.
Brilliant, and I know that Dr. James Mault has indicated you'd like to answer. Go ahead.
Yeah, I think, again, it's a very exciting time because we can see things like, for instance, sleep. We have taken sleep for granted, for decades, and now we can measure and monitor how much sleep, and not just minutes of sleep, but quality of sleep. And we now can relate that with other data sets to outcomes or impairments that occur from poor sleep. And then that transitions into, well, why is the sleep poor? Then we have sleep apnea. So all of these things, wearables and other what we call passive data collection methodologies, allowing us to collect the data to be able to see how these things connect to each other, movement patterns, and even your dietary behaviors. All of that matters. And when we can put it's a broken record for all of us, but it all comes down to putting these data sets together with genomics and other data that allow us to start to see these things. And then 2 things happen from that. One is we can do pattern recognition and algorithm development. But number 2, just as important, we need to be able to have the data to prove the benefit in order to get payment for these things ultimately, because you're not going to see governments coughing up money for new technologies and crazy ideas unless you can show the benefit of those, and so we have to, the burden is on us to show the benefit of giving everybody a DEXA scan.
Okay, fantastic. Anybody else want to talk about?
I just want to...
Can we get the mic to Miriam behind you so we're ready for her question?
So
Dr.
building
David.
off of that comment, I think one of the things that we do have to recognize is that human and consumer behavior has a huge impact on your life. Whether it's what you eat, your exercise, your sleep, and changing behavior is very, very difficult, but not impossible. Now, the thing we have learned is that I call it the digital health paradox, where the people who are most likely to use wearables and things of that sort are the ones least likely to benefit, and those that are least likely to use it are actually the ones that we have to focus on. They have the highest cost. So how do you get an individual that is least likely to exercise, least likely to do your recommendations, and you have all these technologies? Well, I'll share with you an example. We ran a program with Kaiser Permanente, a large health system in the United States, and we looked at a problem called cardiac rehab, and we tried to get these individuals to rehab, and many of these individuals, about 50% of them don't go. It's just too difficult, it's just too long, 6 weeks. And so what we did is we set up a program where they could either go and take it at home, or they would actually go in the hospital, or in the facility. And what we found is that the only requirement, if they went home, is that they would get a wearable and they would get called if they didn't use it. And sure enough, almost everyone got a call on the first day. And with knowing that somebody was actually overseeing was very important, because that was one of the parameters that helped guide whether or not they would actually do it. The second was...
Sorry, I'm just going to interrupt you, Dr. David, because I know that we are pressing for time. I'm going to get Miriam's question in.
Let's just say that behavioral science is a huge component of this, and there are many strategies today that we can apply in conjunction with the technologies.
Absolutely. Sorry to cut you off, but I do want to make sure Miriam gets her question in.
Okay, Dr. David, you may keep your mic because I think my question is to you. So I think we all know that access to good healthcare is still expensive. It's a privilege. And the access to good technology is also expensive. What are your plans to make sure that, for us to be able to create an environment around prevention rather than spending a lot and burdening the governments with the amounts that are paid to good healthcare? What are your plans to make technologies more accessible and make it more effective in terms of cost? From cost perspective.
Great question. Thank you very much. And so, yes.
So many different ways. First and foremost, there are already within the existing data sets that we have a lot of information that we're unutilizing. So whether there's x-rays that have been taken, it could be a dental x-ray, it could be a chest x-ray, CT, there's a lot of information already. And the reason is because we focus on one thing. When a person comes in, they came in with rule out, infiltrate, there's a lot of things there. In the medical record, there's a lot of information. We look in the eye, there's a lot of information. So utilizing what we've already captured, that will in itself be very cost efficient. The second is that the technologies and the cost associated with delivering them need to come down, and they cannot involve healthcare providers. If you are asking a healthcare provider to do more stuff, like capture that information, it's not going to happen. It has to be automated. It has to be technologies that are available anywhere, but also inexpensive. And those are going to be the key factors that drive this forward.
Brilliant. And I really appreciate your comprehensive answer. You knew that I was going to tee up, Miriam, for you especially, Dr. David Rhew. We've actually got another minute on the clock, so I'm just going to get a quick one line from you both, and then we will say halas and go on to the next session. Dr. James Mault, you're back with us, BioIntellisense, but to speak to what Miriam's saying, how do we make prevention accessible to more people in just one line?
I think, as Dr. Rhew said, I couldn't agree more. You've got to find a way to strip out the labor cost. In the United States, 74% of total healthcare cost is labor. And it's the only sector in our economy that has such an extremely high labor expense. And the beauty of it is technology has the opportunity to strip out that labor cost and actually improve care at the same time.
That's a really
all
beautiful
about
way of putting
automation.
That's a really beautiful way of putting it. And Jim Mellon?
I'm just going to make a plea here, which is that we know...
It's not to your insurance company.
No, nothing to do with insurance. The plea is, we know that food is the new tobacco. Ultra-processed foods cause a very large amount of disease burden for healthcare systems. If something could be done about UPFs, if we could reformulate food, force food manufacturers to take out sugar, take out salt, improve the composition of our food, that would be a very long way down towards universal prevention.
Fantastic. And that's a really positive note to end on, Jim. We really appreciate it. And again, that partnership with the Longevity Forum, please do look them up. I know that Dr. James Mault is back with us, and Dr. David Rhew, please do stay with us. They're all very approachable. Any questions that you want to give to them, personally, please do. Big round of applause for our fantastic first panel discussion.